Good evening to all. On behalf of the Rsacp webinar, I welcome all the senior dignitaries present here to this Rsacp webinar on
Dr. Rekha, you are muted.
Yes,
Rekha, you're not audible.
Dr. Rekha, madam, you need to unmute yourself. I think madam is logged. She has logged out, I guess. Probably there's some internet issue.
You give the introductory remarks, Vishal, and hand over to madam till she joins.
Sure, ma'am. I would like to welcome Dr. Nivedita Pani, ma'am, Director, Medical Institute, Bhubaneswar. Dr. Nivedita Pani, madam.
Thank you, Dr. Singla. I first wish a very good evening, Dr. Indrani ma'am, our president, and our secretary, Vishal Singla, and our most adorable secretary of the ISA National, Dr. Naveen, who was always the pillar of strength for us, and all the senior members and the junior members of this our association. First of all, let me say, long live Rsacp. Long live Rsacp. So today's, myself and Rekha, we have decided, let us start with the ECG and capnography. Why we have decided that topic? Because so that this topic is very much helpful for the postgraduates, because there is no need for us to send the cardiologist. We can read it and we can do it very nicely. And capnography, which is very essential during the anesthesiology that everybody knows. So thinking that only we both, Rekha and myself, we have decided. So today's speakers are really excellent, and you will be very happy to know that Dr. Deepak Das, he's a regular teacher of our institute. Whatever, anytime he's an excellent cardiologist, he's the associate professor, and anytime we call him Deepak, please teach our student, and he very jolly well, happily he comes. And he also manages the ethical, our institutional ethical committee. He's the most person, and he guides, and without any hesitation, he guides all the students. And next is Prachi. She is the alumni of this college, and she is now presently at Hyderabad in the NIMS Institute. And I still remember Prachi, when she was a postgraduate student, she was an excellent orator. I wish both of them a very good success for this webinar. And now I think Rekha has joined. So please, over to you, Rekha. Are you there, Rekha?
Yes. I'm extremely sorry for that network disturbance. And I once again, madam has already given a very warm welcome. So I would now request our Rsacp President, Dr. Indrani Kumar ma'am, to kindly give a few words on this webinar. Madam, please. Madam, please unmute us.
Thank you very much, Dr. Rekha and Dr. Nivedita, for your warm words. And I take this opportunity to welcome all of you for this yet another bi-monthly webinar from Rsacp. And this time I'm extremely happy to have Rsacp Orissa taking the lead. And today's webinar, especially as Nivedita already said, is on some basic topics which are very, very important, not just for our day-to-day management of cases, but also for students to clear their exams. And these two are such important topics. And again, I would like to wish, I would say long live Rsacp, and I welcome all the dignitaries who have joined, and also all the members who have joined to participate in this webinar. And I thank Rsacp Odisha for taking the lead this today, and wishing this webinar all success. Thank you very much.
Thank you, madam, for those encouraging words. Normally we have our patron also, Dr. Tejpal sir, but today, unfortunately, I don't know, must have had some problem for which he is not able to join. I would now request our dynamic, our president-elect, Dr. Naveen Malhotra sir, kindly speak a few words and encourage
Dr. Rekha Das. for the warm introduction, but Dr. Tejpal is there. And sir, please
Sir is
unmute
there.
yourself.
I could not see
Sir, please
him.
unmute. You have to make him co-host. Now you are the host. Make Dr. Tejpal co-host so that he can unmute himself.
Welcome, Dr. Tejpal, sir. We are so happy
Dr.
to have
Rekha Das,
Yes,
you are
sir.
the host. Make Dr. Tejpal co-host.
Sir, he is already unmuted.
Okay, please go ahead.
Sir,
Over to you,
please.
Dr. Paul, sir.
Dr.
Thank
Paul,
you, Naveen. Thank you, Naveen, for marking my attendance. Thank you. God bless you.
I am always there, sir. I am always
I
there.
am always there. Same is true over here. Thanks, Dr. Nibedita and Dr. Rekha. Under the guidance
sir.
of Dr. Indrani, Dr. Vishal, Dr. Naveen, for arranging a very important and very crucial basic concepts in anesthesiology like capnography and ECG. To think such an idea is really marvelous. Not only the beginners or even the older generation like me, I am sure is going to be benefited. Every day you learn, you repeat things, you learn many, many things. So I am happy that you have arranged the two topics like ECG and capnometry. Wish you all the best for a successful this
Thank you,
webinar.
sir.
Long live Rsacp. God bless you.
Thank you, sir, for your best wishes.
Sir,
We
thank you,
always
sir.
seek your blessings, sir, whenever we host
Always,
anything, any
always.
webinar or any activity in the Rsacp, sir. So now I would request Dr. Naveen Malhotra, our President-elect, who has done a lot for this society, to speak a few words now. Please, over to you, sir.
Dr. Indrani, madam.
Naveen, sir?
Yeah, I am there. I am speaking. Am I audible?
Yes, sir.
Thank you, Dr. Rekha Das, respected Dr. Paul, sir, Dr. Indrani, madam, dear Dr. Vishal, Dr. Sunil Sethi, and heartiest congratulations officially to Dr. Nibedita Pani on taking over as director of a prestigious institute in Odisha, and other GC members who have joined, Dr. Rakhi Goel, Dr. Mayank, and other things. And very eminent faculty, Dr. Deepak and Dr. Prachikar, and also we have got amongst us Dr. Basant Kumar Pradhan, Dr. Sulutna Dash, Dr. Ranjita Acharya, and Dr. Bimal K. Pandaji, who have all joined to make this webinar very, very successful. And we're almost now nearing completion of 2 years of back-to-back webinars every fortnightly under the banners of Rsacp. We started on 1st July 2020 during the COVID pandemic, and we are now just near to completing our 2 years of the webinars. And soon we are planning to go physical also. And the dates for the prestigious national conference and the other activities will be announced very, very shortly in due course of time. My best wishes to team Rsacp Odisha branch for conducting this webinar. Thank you all the speakers for sparing their valuable time. Thank you very much. Long live Rsacp.
Thank you, sir. Thank you so much, sir. I would now request our our active secretary, Dr. Vishal Singla, to kindly speak a few words. Dr. Vishal, please. Dr. Vishal.
Madam, as told to you, please carry on.
I think he can unmute himself, but I'm seeing all the same.
No, it's all right, Rekha. It's all
Vishal,
right. Oh, Vishal is there. Yeah.
quick words, unmute. Vishal, unmute.
am I audible, sir?
Now audible.
Yes, yes.
And heartiest congratulations to you on
Thank
the
you, sir.
birthday
Thank
of
you.
on the birthday of your son. Heartiest
Thank you,
congratulations.
sir. Your blessings, sir. Your
Oh.
blessings, sir. Thank you to each and every one of you for being here with us today. Rsacp has always been pioneer in promoting academics, as Dr. Naveen has said. We are almost close to 2 years since we are holding the online webinars, and continuing in the same spirit, we'll be holding webinars with the more relevant topics. not only in the field of anesthesia, but also in the fields related to day-to-day life issues. For today's topics, I would like to thanks Team Odisha, Team Bhubaneswar, for bringing in the very relevant and so important topics that any mistake in these two aspects is almost unpardonable now. We have equally important and impressive speakers with us and equally important chairpersons with us. I would also like to thanks Dr. Naveen Malhotra sir, Dr. Indrani ma'am, Dr. Sunil Sethi sir for constantly pushing to keep the standards of the RCCP high. And I would also like to thank Mr. Chaubeji for the technical support and providing this webinar on different forums. This webinar is live on YouTube as well as on the Anesthesia TV. Also, I would like to make a request to all the PG students, whosoever we have in the webinar, that please come up with your questions. No question is small. Please come up with your questions. Once again, I would like to thank every one of you for being here with us today. Thank you very much.
Thank you, Dr. Vishal, for those encouraging words and for all those important messages that you left. Now we go over to our first talk. Our first speaker of the talk is Dr. Deepak Das. He will be speaking on ECG at fingertips. For this, I would like to invite our chairperson, Dr. Sulochana Das. Dr. Sulochana Das is a professor in the Department of Anesthesiology from IMS Some Hospital, Bhubaneswar. Her area of interest is regional anesthesia and pain management. And she has 11 original articles and five case reports. And I've seen her as a very active anesthesiologist and has a lot of contribution to IMS Some Hospital. Our next chairperson is Dr. Ranjita Acharya. She is also the professor in the Department of Anesthesiology from IMS Some Hospital. And her area of interest too is regional anesthesia and nerve block. And she has also a few publications to her credit. And both of them work in union and have done a lot for the postgraduate students for the upliftment of IMS Some Hospital Department of Anesthesia. And they are a source of encouragement in Bhubaneswar, and they're leading the branches also. So with these few words, I now invite our chairperson to introduce our speaker, Dr. Deepak, and then so that he can start off with his talk. Now over to the chairpersons, please.
Thank you, Madam. So much, ma'am. Good evening, everyone. The first topic of today's session is ECG at fingertips. Presented by one of our eminent figure of Department of Cardiology, SB Medical College, Dr. Deepak Ranjan Das, presently working as an associate professor. He is one of the reviewer of Indian. He is one of the reviewer of Indian guidelines on hypertension and Indian Heart Journal. And he is a great academician and has contributed many chapters in various textbooks. And he has more than 60 publications in index medical journals. He has received fellowship from the American College of Cardiology, European Society of Cardiology, Society for Cardiovascular Angiography and Intervention, and Cardiological Society of India and Indian College of Cardiology. Sir, now over to Dr. Deepak Ranjan Das, sir. You may kindly start. Thank you.
Rekha madam has to stop sharing so that I can.
Yeah, you have been given the opportunity to share the slide. Kindly share your slides, Deepak. Yes.
Are my slides visible now?
Yes, yes.
Yeah. So, a very warm evening to all the dignitaries of Rsacp, my seniors and mentors, Rekha madam and Nivedita madam, who have guided me in different times of my life, and they have been a constant source of encouragement to me in different times. It's in fact not just a pleasure, but definitely a privilege to share some of the important tips about interpreting this to our anesthesiology students and colleagues. So, when we go to this is the man who came this concept of electrocardiography. He is William Enthoven. And this is the triangle based on which all the interpretations of ECG are formulated. This is called Enthoven's triangle. So, this is the immortalized photograph. The first ECG machine, some of you may be actually awestruck that this was the first ECG machine, and he himself, Dr. William Enthoven, is actually coming out with fast electrocardiograph. So this is a beaker or a large container which contains salt water, and one of his legs is dipped into that, the other leg touching the ground. And this is the machine which comes up with a printed paper that recorded the fast electrocardiogram in a human being. So we have not just evolved, we have moved maybe 1,000 miles ahead from this fast photograph over a span of last 100 years. Just few years back, we have celebrated 100 years of electrocardiography. And these are the typical nomenclatures with which we identify the electrocardiogram. The P wave, the QRS complex, the ST segment, the T wave, and in some cases, the U wave. And the different intervals, the PR interval and the QT segment. So essentially, an ECG is an overview of electromechanical coordination. That means there is an electrical activity which produces the mechanical output of the heart, and that coordination is done by the electrocardiogram. So the mechanical contraction of the heart is due to the electrical activation of the heart in an orderly fashion. So by electrocardiogram, we are trying to assess what is this orderly fashion, or is there a disorder? So a disorder in that fashion will give rise to the abnormalities which we are expected to detect. Now, there are specific waves that appear on ECG which correspond to both the mechanical and electrical depolarization, because from the ECG, you definitely get an impression about the electrical activity, but more important than that, you can also get an inference about the mechanical activity of the heart as well. So we know that these are the ventricles. This is the left ventricle, this is the right ventricle, this is the left atrium, this is the right atrium. And this is the superior vena cava, and this is the atriocaval junction. So this is the site where the sinus node is located. So sinus node is the natural pacemaker of the heart from where the impulse arises. And after the impulse arises from the SA node, it traverses to both the atria, which gives rise to the atrial depolarization of the P wave. After that, it has to pass through AV node or ventricular node, which is indicated by this PR interval. Then it has to pass through the bundle of E's and the bundle branches, and subsequently it will depict the QRS complex, and as it goes to different parts of the ventricle, depolarizing the ventricle, the QRS complex will be completed, and then there will be a phase of repolarization, which is the plaque phase, which we get as ST segment. And then the ventricular repolarization is depicted by T waves. So the normal sequence of impulse conduction in the heart starts from SA node, goes to AV node, to bundle of E's, bundle branches, Purkinje fibers. This conduction is done through specialized conduction system. So these are the different components of the specialized conduction system of the heart. Now, when you think of PQRST, wave indicates atrial depolarization. QRS complex indicates ventricular depolarization, and T wave indicates ventricular repolarization. A question may come to mind of some of our students that ventricular repolarization there, atrial depolarization is there, atrial repolarization where it is. In fact, the phase of the atrial repolarization is superimposed by the QRS complex and the T wave. That's because they inflict a bigger electrical deflection on the ECG. That's why this is submerged. So atrial repolarization is submerged. So when we come to interpreting an ECG, let us make it very clear in our mind that interpretation of ECG is never absolute. It is in fact unfair to show someone an ECG and ask him or her to make a diagnosis. It is always contextual. What do I mean by contextual? Exactly the same ECG can have two completely different interpretations in two clinically different scenarios. And the appearance of, and for anesthetist, these second 2 points are extremely important because most of the times they do see ECG, but they do see it on monitors. So the appearance of ECG in the monitor may not be exactly replicated in a surface ECG. When we say ECG, it is the ECG, the surface ECG, or the ECG tracing that you take on a paper, be it single channel ECG or 2-channel, 3-channel, 6-channel or 12-channel ECG. Those are the ECG. So there is a certain modification, and that is called a Mason-Leaker modification. Mason-Leaker modification means an ideal ECG should be recorded with the leads placed in the left lower limb, right lower limb, left upper limb at the wrist, and right upper limb at the wrist. But many a times when we look at the monitor, the ECG tracings are not from those sides, but these are called approximation towards the trunk. So you keep it on the abdomen or maybe on the shoulders or at the back. So these sort of modifications are called as Mason-Leaker modifications. We should be very clear because of these. What you find in the monitor may not be exactly same if you take a surface ECG. So when in confusion, please ask for a surface ECG always. So let's start with a case. And this case is essentially meant to highlight the fundamental thing that interpretation ECG is always contextual. Always contextual, never absolute. So let me read out the case for you. It's a 54-year male, diabetic for 14 years, hypertensive for 10 years, on human mixed at 34 units with antihypertensive telmisartan plus clothianidone 80 plus 12.5, rosuvastatin 10. Presents with shortness of breath class 3, 4 hours duration. This is the ECG. So what I will request, since there are postgraduates, in between I would like to have your opinion, suggestions and answers. That will make it really interactive. Otherwise, there is no fun in giving a didactic lecture about ECGs as it is being taught in undergraduates or postgraduates. So I think all of you must have had a fair bit of look at the ECG. This patient was admitted to a corporate hospital at 5:40 a.m. And we know they sent the different profiles. So the profile 3 was sent by the general duty medical officer. The patient was given oxygen by nasal mask. Blood pressure found was 180 by 100. The patient was started on nitroglycerin, 15 microdrops per minute. A call was given to the cardiologist. Troponin T was sent. Patient was restless and tachypneic. Now we know this is an unseemingly and unearthly duration of time, 5:40 a.m. The call was given to cardiologist, but it's extremely difficult to get a cardiologist at your beck and call at these times. So the patient continued to remain asymptomatic. So the GDMO did another ECG after 2 hours of the first ECG. By this time, the cardiologist has not arrived. So I will request the postgraduates to unmute and answer. What needs to be done? This is the ECG. You have seen the first ECG. This is the second ECG, which is taken 2 hours after the first ECG. We'll be happy to get some response.
And nobody is replying. I'm just waiting for at the chat box to see if anybody is writing something there. But I think many have logged in, but there's no reply from anybody.
So, yes.
Obviously, yes, we got it. Ventricular fibrillation. No, VT, ventricular tachycardia, that is. No, ventricular fibrillation, somebody has written.
So, somebody has written ventricular fibrillation, second ECG. Well, that is not correct. Anyway, so we'll clarify all those doubts. So, for then we'll be happy if we get some other response. But the as Rekha Madam has already suggested, this could be VT. But I always tell that ECG needs to be contextual. So this ECG is done in the patient where the previous ECG was done. And if you look to the previous ECG, then what is so obvious when you look at these T waves? These are all picked, tinted, and T waves with very narrow base, which is characteristic of a certain electrolyte abnormality about which anesthesiologists are extremely cautious. And we know, yes, Alok has suggested wide QRS in second ECG is very correct. Wide QRS. So the ideal answer should be it's a wide QRS tachycardia. And somebody says WPW first ECG followed by VT. So why do you say WPW? Because all the P waves are seen and PR is normal. We know that fundamental to WPW is there has to be a short PR interval. The PR is perfectly normal. So it is obviously not WW, but it's a hyperkalemia. Somebody has suggested hyperkalemia correctly. So what we'll see is by this time, so we think that this is VT. Now the cardiologist comes. What the cardiologist does is he sees the first ECG and the second ECG, and then he knows that this, though it looks like VT, it's a wide QRS tachycardia, but it's not VT. So what he has advised is, he has advised 2 ampoules of calcium gluconate injection. And after administering 2 ampoules of calcium gluconate, we look at the ECG. The amplitude or the tinted appearance of the T waves have come down, though the sinus tachycardia persists. So essentially, if we look to a wide QRS tachycardia, one of the differential diagnoses is obviously ventricular tachycardia, and it's the commonest diagnosis. But in certain instances, it could be sine wave pattern. So that's the sine wave pattern of hyperkalemia. So this is just to give you an idea that all the time when we look at an ECG, we must take into consideration the clinical context in which this ECG is taken. Now, for beginners, you should be thoroughly confident about looking at an ECG paper. And when you look at an ECG paper, you must know that usually the standard speed at which an ECG is done is 25 millimeter per second. So machines have a facility to take the ECG tracing at 12.5 millimeter per second or 50 millimeter per second. So if you have a very fast rate and you would like to slow down the ECG, then you can come down on the ECG speed. And if you have a very slow heart rate and you'd like to increase the speed of the ECG roll, then you can go to. But this is what is standard. In a standard, there are small squares and these are big squares, so big blocks. One big block contains 5 small squares. So when it is 25 millimeter per second, each small square is 0.04 second. And one large block is 0.04 into 5, that's 0.2 second. And when we think of the y-axis, that's about the x-axis. When we think of the y-axis, that indicates the voltage or the amplitude of the current. So that's 0.1 millivolt for a small square, and for a block, it's 0.5 millivolt. So with these basics, we'll know how should we proceed to analyze an EKG. We know that the world around, it's moving from ECG to EKG, but which you use it interchangeably. Most of the American textbooks you will see, they will mention EKG. So electrocardiogram, just to differentiate it from ECG, which can stand for electrocorticogram. So first we should have an idea about rate, rhythm, axis, P wave, PR interval, QRS complex, ST segment, T wave. So this should be ideal way of learning an ECG. But as you see ECG more and more and make your own interpretation, sometimes you may not follow this sequence of analysis. But for all beginners, this is how one should try to interpret. Now, first is rate. Is rate important? Extremely important, because that gives us a very important information about overall clinical condition of the patient. If the rate is very fast, you know something could be wrong. Sepsis can give rise to, respiratory distress can give rise to, or if the rate is very slow, it could be impending cardiac arrest. So assessing rate is extremely important. Now we know the normal heart rate is 16, but normally when we say rate, we mean the ventricular rate or the QRS rate. So 1500 divided by PP interval will give you arterial rate. 1500 divided by RR interval will give you. So if you have a conduction disturbance like conduction block, you could have bradycardia, and you could have several instances which can give rise to tachycardia. So how do you calculate the rates? So you can count the number of QRS in a 6-second strip and then multiply by 10. So let's say if there are 5 QRS in a 6-second strip, then 50 is the heart rate. So what you need to memorize is, you need not calculate all these things. If there is just one big square which comprises of 5 small divisions, your heart rate will be 300. If there are 2 big squares, the rate will be 150. If there are 3 big squares, the rate will be 100. If there are 4 big squares, the rate will be 75. If there will be 5 big squares, the rate will be not 50, it will be 60. So the normal heart rate will vary from 5 large blocks, 3 large blocks, between 60 and 100. So if you look at an ECG and you find there are more than 5 large blocks, then you know there is bradycardia. If you look at an ECG and you find that less than 3 large blocks, then it is tachycardia. It's as simple as that. So we'll have, so this is, if there are 6 large blocks, then the rate is 50. If there is 5 large blocks, 1, 2, 3, 4, 5, then it is 60. If there are 4 large blocks between QRS, it is 75. 3 large blocks is 100. So if it is more than 5, bradycardia. If it is less than 3, tachycardia. That's very simple. So let's practice with an example. So what will be the rate like? Just an approximate idea. Yes, we are trying to see your response in chat box. Yes, very good. Someone has 50. Prachi. Prachi, I always say that she was one of our most say outstanding students, and Manika Agarwal, she says it's 60. Okay, let's see how many bigs. 1, 2, 3, 4, 5, 6. Oh, so if 6 big squares are there, then it is 50. So, okay. So if there are 5 big squares, it is 60. If there are 3 big squares, it is 100. If it is between 3 and 5, the rate is normal. If it is less than 3, it is tachycardia. If it is more than 5, it is bradycardia. So, so what's the rate based on the rule? If you say 50 beats per minute, you are correct. So then you actually analyze the rhythm. So when you analyze the rhythm, you ask certain very fundamental questions. First is, the rhythm is all about the P waves, because we know the heart's conduction system initiates its rhythm from the SA node, which is the natural pacemaker of the heart. So you have to find if the rhythm is regular, means the pacemaker is generating impulses regularly. So whether the P waves are regular or irregular, you look at the P waves. This is a P wave, this is a P wave, this is a P wave, this is a P wave. Are the P waves regular? Then are the RR intervals regular? After looking at the P wave, you are looking at the QRS complex. So this is a R, this is another R, this is another. Do they appear regular? Yes. And is the RR interval measurement normal? Is the PR interval normal? Because PR is the conduction through the AV node. Normal PR interval is 0.12 to 0.2 seconds. If it is less than 0.12, we say short PR. If it is more than 0.20, we say prolonged PR interval. So the PR interval is constant and it is normal. Then you have to analyze the QRS complex. You have analyzed the P, you have analyzed the PR, then you analyze the QRS complex. So what is the width of the QRS complex? The width of the QRS is from the initiation of Q to the end of S. And we know that all QRS complex will not have the 3 elements. Something may be like QR complex, something it may be RS complex, sometimes it may be QS complex, but basically we call it a QRS complex. So is the QRS complex normal or wide? How do you say? If the QRS is greater than 0.10, 0.10 means 1 small square is 0.04, 2.5 small squares is 0.10. So if the total QRS duration is greater than 2.5 squares or 3 squares or more, then you know that the QRS is wide. Otherwise, it's normal. So QRS is 0.02 to 0.10. Then after QRS complex, you look to the Q waves. Normally, whether they look normal, inverted, or they're picked, or any abnormality that you would comment. And after that, the ST segment. This is the ST segment. So this ST segment, whether it is normal, it is elevated, depressed, so that impression you have to give. So if you give your impression, then you can arrive at a conclusion. Then in some certain instances, we have to also assess the QT interval. And QT interval, let me tell you, is something which varies from male to female, but just I've given just a gross idea. If it is 0.44, if more than 0.44, we say prolonged QT interval. And we know for anesthesists, prolonged QT is very important because prolonged QT gives rise to arrhythmogenesis. Arrhythmogenesis means the tendency to give rise to cardiac arrhythmias. And finally, is there in ectopic? Ectopic means which does not follow the regular sinus rhythm pattern. So finally, if you look at this ECG, what will be your interpretation? The rhythm is regular. P waves are identical. There is a P wave for each QRS complex. So PQRS, 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 PQRS. So atrioventricular synergy is maintained. Is the rhythm regular? Are the P waves identical? And PR interval is normal, that is 0.16. And QRS wide, normal or narrow, it's normal, 0.08. Is the wave peaked, inverted, flat? No, it's normal. And is the ST segment elevated or depressed? No, ST segment is not. So that says this ECG and QT interval is say 0.36, which means it's normal. So, and if there is no ectopic, we say this is a normal sinus rhythm. So many times you find that the cardiologist mentions NSR. NSR means normal sinus rhythm, which essentially says that it is a normal ECG. So we'll go to certain, I will just highlight the important aspects which the anesthesiologists need to know. And this is about very commonly we find chamber abnormality. And I will not tell about all chamber abnormality, but only that chamber abnormality which is the most important amongst the different concepts. And that is a left ventricular hypertrophy. So LVH is quite common because we know that overt and covert hypertension is rampantly present. Many a time you will be examining somebody for a pre-anesthetic evaluation. He says that he never had hypertension, but first time you measure and you find that his blood pressure is 160/90. So whether it is a blood pressure rise due to just anxiety for undergoing surgery, or he has had hypertension which has remained undetected. How do you know? Very important and subtle information you can get by looking at the ECG. In the ECG, if you get an evidence of LVH, you have all the right to suspect that he is a case of chronic hypertension, and it's not just hypertension due to anxiety or stress. And we have so many, more than 11 criteria to quantify LVH. The common one is the Sokolov-Lyon criteria. You measure the S in V1 or V2, add with R in V5, V6, if it's more than 35. This is common. But amongst the different criteria, the one which can be used with much higher sensitivity and specificity is Cornell criteria. We call it Cornell voltage criteria, whereby you add the R wave in AVL with the S wave in V3. If it is greater than 20 in female, you can suspect LVH. If it's greater than 28 in male, you can suspect LVH. Besides LVH, what we need to assess is the ST or T wave abnormality, which are commonly seen with LVH. So many times you will find an impression LVH with strain. What does that strain mean? A strain could be either systolic strain or diastolic strain. Essentially means a pressure overload situation giving rise to systolic strain. The prototype example is aortic stenosis. Because of the obstruction to the aortic valve, the left ventricle has to exert the blood with greater amount of pressure, greater amount of force. So there is a pressure overload, systolic strain. And in aortic regurgitation, more amount of blood is going into the left ventricle. So the volume overload occurs during the diastole. So that's a diastolic strain. So these are mainly two types of strain. And this is a very common ECG. I think all of you can appreciate that there is definitely LVH. He is a 45-year-old man with hypertension. You look at the S wave in V2. This itself is somewhere around 25 or so. And if you add it to the R wave in V5 or V6, that's more than 45. So definitely there is LVH. But what is important is if you look to these ST segments, you find that there is ST depression. So these ST depressions are indicative of systolic strain or hypertension with LVH and strain. So this is the example that I wanted to show to our postgraduates to get a feel. But the next thing is for you to answer. He's a 24 years young man with syncope while playing football. So first you have to find out, is there LVH in the ECG? If the people feel that there is LVH and there is also ST depression, so what do they think? This is LVH with strain or something else?
Deepak, can we finish it in a short time?
Yes, we'll. So, yes, Prachi has, she has sigh. So, please remember, when you get these type of T-wave inversions with LVH, and these are typical arrowhead type, this is not the typical LVH with strain. It's something very sinister. In a young man with contact sports, sudden syncope, you must have read so many instances. This could be hypertrophic obstructive cardiomyopathy. So now we'll go to the important arrhythmias. Important arrhythmias are atrial fibrillation, flutter, ventricular fibrillation, ventricular tachycardia, third degree AV blocks. Of the different blocks, we'll only highlight complete heart block and asystole. So there are 1,000 types of arrhythmias, but these are the common arrhythmias which will require your attention. And the commonest one, of course, is atrial fibrillation. We know that basically it will be irregular. And the atrial rate is 350 per minute, but it's basically theoretical or electrophysiological. You will not be able to calculate it. What you will find is absent of P waves or inconsistent P waves. And there could be fibrillatory waves, means very thin lines. Then you can get a sawtooth-like appearance, which we call as atrial flutter. So typical sawtooth-like appearance, and the important thing is the RR will be regular. So usually the atrial flutter is conducted with either a 2:1 conduction or a 4:1 conduction or a 6:1 conduction. So the ventricular rate or the R rate is regular. Then, as somebody was suggesting in my previous ECG that it was ventricular fibrillation. Ventricular fibrillation are just undulations of the baseline. You don't get any definite QRS complex. Then whenever you find a wide QRS tachycardia, tachycardia means if you look at the RR interval, it is less than 3. If it is less than 3 tachycardia, you look at the QRS width. If it is more than 120 milliseconds, it's a wide QRS tachycardia. And the commonest wide QRS tachycardia is VT. So that should be how we'll be approaching. And we know that VT in other terms is called widow maker because the overall incidence is more in male and it's fatal. That's why many female become widows, so that's called widow maker. Then amongst bradycardia, the commonest one that we come across is a complete heart block or a third degree AV block. We know AV block can be first degree, second degree, and due to paucity of time, I'll only highlight the third degree AV block. So third degree AV block means the P waves, there is atrioventricular dissociation. We know that the P waves are coming regularly. These are the P waves which are coming regularly. The QRS intervals are also coming regularly, but there is no atrioventricular association. So each P wave is not followed by a QRS complex. So there is atrioventricular dissociation, which says that it's a case of complete heart block. And when many a time you find that the ECG goes on like this, but people are not sure. When you get a straight line or just a crudely unrelenting baseline, this is asystole, and basically it says that the person is cardiac is dead. Now, most of you will be required to attend to patients in ICU. This is a brief important input about a patient in ICU. 58-year female, diabetic for 11 years, hypertension for 9 years. The person never had symptoms of shortness of breath or palpitation. At some point of time, she was advised to take warfarin. Warfarin is a vitamin K anticoagulant. She had done her last PTINR 10 months back. So the reports are irrelevant. Now she has developed weakness of left-sided limbs. Admitted to ICU, blood pressure found to be 106/70. The CT scan of the brain is done. What you find so obvious here is a large infarct. And she has an ECG which is done from the casualty like this. So can I get response from some of the people who can put in their ideas and just look at the ECG? It won't be much difficult if you are looking at ECGs. It's so obvious. You can look at here. These are the different ECG strips.
Safe, no?
So this is obviously irregular. Irregularity is clearly written on the ECG. So obviously this is atrial fibrillation. Just to highlight,
Yes.
with atrial fibrillation, the chance of an embolus getting dislodged from the atrial appendage and subsequently getting dislodged in the cerebral circulation, giving rise to stroke. Another case scenario, 73-year male. These are the history. He has irregular fever, dysuria, altered sensorium. Diabetic for 12 years on insulin plus oral antidiabetics. Hypertension for 9 years is on amlodipine and telmisartan. Creatinine 1.5. Sodium 118, potassium 5.6. TLC 18,000, neutrophil 78%. This is the ECG. If you look at this ECG, what is the first question you would like to ask? I think the diagnosis is written on it, but the important question is not the diagnosis. If you look at the ECG, it is obviously wide. Wherever you find, it's almost 0.8. So QRS is wide, and that is tachycardia. So wide QRS tachycardia, first diagnosis you should entertain is VT. And when you look at this ECG, what's the first question you would like to ask? Can I request Prachi to send in her response? When you look at this, because this is important. How do you manage a case of VT? When you look at, yes, Prachi? When you look at an ECG like this, and you have made your diagnosis, let's say VT, what's the first question?
Look at the electrolytes, no?
So when you look at an ECG like this, the only question you would like to know is what is the systolic blood pressure? Because a VT will be managed based on only single criteria, that is whether hemodynamic compromise or there is no hemodynamic compromise. And we define hemodynamic compromise based on the systolic blood pressure. If it is 100 above, we say there is no hemodynamic compromise. If there is 100 or below, then we say hemodynamic compromise. That says what modality of therapy you are going to give. If there is hemodynamic compromise, there is only one therapy. That is, you have to go for electrical cardioversion or DCSA. If there is no hemodynamic compromise, then you have the opportunity to ask several questions, do several tests, because that's a relatively stable situation. Once you find that there is hemodynamic instability, that's an unstable situation. First thing is to revert the VT to sanosedim. Otherwise, it will give rise to cerebral hypoxia and the leading complications. This ECG, what is the diagnosis? I'll give you a clue. Just look at the rhythm strip. Normally, in a 3-channel ECG or a 6-channel ECG, the rhythm strip is something which, so you look to the ECG, this is the rhythm strip. Is it regular or irregular? Obviously, it is irregular. So if it is irregular, shall I say that this is atrial fibrillation? Well, the answer is no. Because if you look to the rhythm strip, everywhere you find a PQRS, a PQRS, a PQRS, a PQRS. Everywhere there is a P wave which is followed by a QRS complex. So this is another cause of an irregular rhythm strip. This is called something called as a MAT, multifocal atrial tachycardia. One of the commonest situations where the MAT is seen is chronic obstructive airway disease with either persistent hypoxia or persistent hypercapnia as well. So now we have a capnography session following this. So that will be interesting. Next, we come to bundle branch blocks. We know two types of bundle branch blocks. One is left, right, and each bundle branch block can be complete or incomplete. Completeness depends on whether the QRS duration. If it is more than 3 small squares, that's 0.12 second, we say complete. If it's less than that, we say incomplete. And when you look at, you try to appreciate the left bundle branch block, look at these 3 leads. Look at lead 1, it will be upright and wide. Look at V1, it will be, say, negative and wide. Look at V6, it will be upright and wide. So these are the 3 leads which you should look for. And these are the different criterias. I will not go into it. Then the right bundle branch block. In right bundle branch block, you look at the same things, but most important is V1. In V1, you will find an M pattern or R, S, or dash pattern. And you will find a slurred S wave. This is a PQRS complex. This is a slurred S wave in lead 1 and V6. Right bundle branch block is R, S, or dash. We call it a rabbit ear pattern. So these are different criteria. Then we come to ischemia and infarction. Everybody is fascinated to make identification of ischemia and infarction. So in order to identify ischemia and infarction, you should be very thorough about this part. This is the QRS complex, the ST segment, and the T wave. And the point where the QRS complex and ST segment meet is called as the J point. And you will find about ST elevation, ST depression. So when you say elevation or depression, you must know elevated above what or depressed above, below what. So that is something called as isoelectric segment. And the isoelectric segment is the TP segment. So the TP segment cannot be found from one complex, can only be found from 2 consecutive comments. So this that is from the end of the T wave of the preceding complex to the initiation of the P wave of the succeeding complex. That's the TP segment, which is the isoelectric segment. So whenever you say elevated, you will compare it with the TP segment and say whether it is above or it is below. And another important thing, which is an early indication, is J point. So whether the J point is maintained like this or it is curving like this. So that gives you and in ischemia, there are certain parts. You could get Q wave, you could get ST elevation or depression, and you could get different sequential deformations of the P wave. So depending on the zone of infarction, how it progresses and how it depicts the electrocardiographic representations. And you see, this is the ST segment at baseline because you are measuring the ST segment with the TP segment and you find that isoelectric. When you say ST segment is elevated, this is the TP segment. The ST segment is above this. So this is ST elevation. And when you say the ST segment is depressed, this is the TP segment. The ST segment is below it. So this is ST segment elevation could give you an appearance like this. And how much ST elevation? You assess the TP segment, you find the ST segment and the difference. This is 4 millimeter of ST segment elevation. And when you say ST segment depression, it is not uniform. It could be 3 different types. Either it is down sloping, or it is up sloping, or it is horizontal. And the down sloping and the horizontal are characteristic of ischemic pattern. But upsloping can be due to 1001 different causes, mostly not due to ischemic. And we know this is how an ischemic phenomenon ultimately manifests. Starts with ischemia, produces injury, finally lands up with infarction. When you say infarction, that means the tissue is dead, so the representation is by a Q wave in ECG. But these sequence of events can happen. You can find a change in ST contour. You can find a change in T wave elements also. And these are transmural, in fact, means through and through. So, which is usually representative of ST segment elevation. So this is through and through. And when it becomes old, you get a Q wave or a healed, in fact, as it is told. Or you could get subendocardial. Subendocardial means it's not involving the whole of the myocardium, involving only the portion. So this is usually reflected as ST depression. Very rarely can be represented as ST depression, but usually as ST depression. Then one of the important manifestation is hyperacute TUS. Before actually the ST segment changes appear, sometimes you may get hyperacute TUS, and you could actually suspect that is there hyperkalemia. So the only difference between a hyperkalemia, hyperacute SARP TUS, and an ischemic SARP TUS is in a hyperacute TUS of ischemia, the base is broad, whereas in hyperkalemia, the base is narrow. And then we come to Q waves. Q waves are important because at one point of time, myocardial infarction used to be divided. When I joined my MD medicine way back in 1996, the myocardial infarctions were divided as Q infarct or non-Q infarct. Over a period of time, the concept have changed. Now the myocardial infarction, either ST elevated myocardial infarction or non-ST elevated myocardial infarction. So there can be Q wave normally like in lead 3, but if it is less than 2 millimeter, it may be normal. Pathological Q waves, whenever it is more than Q waves, we should always try to find out some pathology. And in ischemia context, it's usually a myocardial damage from an infarct. So, in an ECG, yes,
I would like to interrupt. Yeah, can we just wind up soon? Because
yes, I will wind up. I'll wind up.
Thank you. Thank
you. So, if we look for ECGs, then you have to find out grouped, means not just one, but multiple interpretations, ST depression, ST elevation, and Q waves. And this is just to say that it is an anterior infarct. So you look to the anterior leads, V1, V2, V3, V4, and it is anterior lateral. You find the ST elevation in lead 1, AVL, and V5 and V6. If it is an inferior infarct, it is due to right coronary artery involving this diaphragmatic surface, you look to lead 2, 3, and AVF. So there are Q waves. So I think that finishes most of the important informations I would have loved to give. The rest of the things would have been interaction. Due to paucity of time, will not be able to interact. So thank you for your patient hearing. In case you have any queries, we'll be more than happy to take your queries.
Thank you, Deepak sir. It was a nice presentation and thoroughly you have explained everything. Though there is lack of time, still it would have been very helpful to our PGs. Thank you so much. Any questions anybody wants to ask? PGs?
Can I just say something?
Yeah.
Please, madam.
Madam, please.
Dr. Das, thank you
Yes.
for an excellent teaching session on ECG, and it was very, very impressive, and more so because you made it interactive. I mean, it just kept us wanting for more. You know, it's unfortunate that we have that Rekha is asking you to wind up, but it is true that we are short of time.
Madam, actually, I was also really enthralled with I was going on hearing what you were saying, but I suddenly realized we have crossed our
we are
time.
running short of time, and it is unfair for the next speaker. I agree to you on that. But you kept us wanting for more, definitely. And thanks for making time for us in spite of your busy schedule. Thank you very much. Really appreciate your lecture. Thank you so much.
Thank you, Dr. Deepak. It was an excellent and such an elaborated talk. I myself also revived my knowledge. I probably have forgotten so much of ECG until I really heard you, and I feel so nice and refreshed. I'm sure all of them must have really learned a lot today. And I wish we could hear you more, but I hope you understand that we have a limitation of time, and there is another speaker waiting. And she is also saying that, Madam, it is okay, fine with me. And I can finish off my talk in 20 minutes, not an issue. And it was a very nice gesture of her. So thank you again for this elaborate talk and an excellent session that kept all of us really wanting to hear more and more of it. Thank you again. So now we go over to our next session, that is perioperative capnography, and the speaker is Dr. Prachi Kaur. She is from KIMS, Hyderabad. And to chair this session, we have with us our senior professor, Dr. Basant Pradhan, who is a professor and HOD of anesthesiology from the PG Department of Anesthesiology and Critical Care, MKCG Medical College, Berhampur. Sir is a very well-known teacher of anesthesia, and he has made a tremendous contribution. He was a past president, the secretary of ISA Odisha State Branch. He was a past vice president of ISA Bhubaneswar City Branch, and he has been an invited speaker at the national, zonal, and the state conferences. He has 32 publications in Indian Journal of Anesthesia, in Indian Journal of Pain, and various other journals. And then we have a second co-chairperson, Dr. Bimal Krishna Panda, who is a professor in anesthesiology from Burla, from the Vimsar Institute, Burla. It is an autonomous body, and his area of interest is perioperative pain relief and chronic pain management. Dr. Panda is also a very active ISA member. We find his presence in many conferences, and many of you must have seen him actively participating in these places. Now over to the chairperson. Dr. Basant Pradhan, sir, please. Sir, please unmute yourself and introduce the speaker. Basant, sir, please. Basant, sir, please unmute yourself.
Hello.
Sir,
Am I
please.
audible?
Yes,
Am I
please
audible?
introduce the speaker. Yes.
Say a warm welcome to all. Thanks the Rsacp President Madam Indrani Madam, as well as Singhal Secretary Dr. Singhal, for giving us the opportunity to ISA Bhubaneswar City Branch to host this academic webinar. So the task is giving for the introduction to our speaker, Dr. Prachi Kaur, who is a speaker on the topic capnography, and also who did her MD anesthesiology from SCB Medical College, Cuttack, when I was also a faculty of that college, and completed her PDCC from London, at present working as an associate professor at Nizam Institute of Medical Sciences, Hyderabad. She has many publications as original research articles in PubMed and other index journals up to her credit. Her field of interest is cardiothoracic anesthesia and teaching simulation. I welcome Dr. Prachi to start her session on capnography, which is included as an essential desired monitoring device by ISA on 30th December 1999. Along with pulse oximetry monitoring, it can prevent up to 93% errors of the untoward events during anesthesia practices. Now, over to Dr. Prachi for a session on capnography.
Thank you, sir. And my sincere thanks to Dr. Rekha and Nivedita ma'am for having given me this opportunity. And a big congratulations to Nivedita ma'am also for a new role as a director. So without much ado, I'll continue with the topic. So perioperative capnography, as we all know, it's very important and an essential part of anesthesia day-to-day monitoring. So over the next 20 minutes or so, we'll have a look at history of how capnograph became an essential monitoring tool and why should we use capnograph, the physics and technology behind ETCO2 monitoring, the types of monitors, a description of the typical capnograph, some clinical examples that are very important in identifying intraoperative situations, and lastly, we'll discuss some case scenarios. So have you ever pondered what are the ASA monitorings? We all know it's heart rate, ECG, SpO2, capnograph, and temperature, along with the presence of a vigilant anesthesiologist. But why? Why all these important? Why these things were used as a essential monitoring status, especially the capnography? Now let's go back in time to have a look at the history of why capnograph was introduced as one of the essential monitoring tools. In the early 1970s, there were many critical increases in medical malpractice lawsuits in the United States. And the then ASIP president, Dr. Elson Pierce, was really concerned about the anesthesia deaths which were caused because of late recognition of accidental incorrect placement of endotracheal tube inside the esophagus. Very unfortunate, of course. So the ASA wanted to prevent these issues. So in 1985, that's almost a decade later, they came with the first set of recommendations. And this emphasized the use of ETCO2 as a monitoring tool. However, this recommendations didn't actually have any randomized studies to support them. So in 1989, they did a retrospective analysis and they saw that 88% of the malpractice insurance claims and 66% of malpractice insurance premiums were reduced if ETCO2 alone was used as one of the monitorings. So in 1990, finally, they came up with the ASA standards, which we use the basic standards that came up, and it recommended that pulse oximetry and capnography should be used for all anesthesia procedures. The question is, why capnography? Now, if we look at this diagram, what we can see is it actually takes care of all parts of your anesthesia circuit, the respiratory system, the cardiac part, the pulmonary circulation, and the ventilation also. So in fact, if we're using a capnography, we can know if there's a circuit kink, disconnection, or leak, if there's an inadequate fresh gas flow, if there's a problem with the carbon dioxide absorption, also if there's a faulty ventilator or a malfunctioning ventilator, if by chance you put your tube into the esophagus, so there is a disconnection of the circuit, if there's an airway obstruction like bronchospasm or a foreign body in the tube or mucus plugs, if there's an apnea, hyperventilation, especially in patients who are spontaneously breathing. But that's not all. It actually also looks at the heart, the cardiac part. It will also give you a clue about reduced cardiac output, hypovolemia, and hypotension. And also metabolic conditions like higher metabolic requirement like fever, thyrotoxicosis, or malignant hyperpyrexia can also be seen in the ETCO2 curves. So next, coming to terminologies, capnometry and capnography are the two terms that is used. The capnometry is a measurement and display of carbon dioxide in the digital or analog monitor. So basically, it's the display of the value. And capnography is a graphical display of the CO2 concentration versus time in a time capnograph. So I understand the technology behind capnography. It was a little boring, but as this is a postgraduate question, I guess we need to know a little about it. So there are 5 physical methods, physical principles rather, I would say, by which the capnography is measured, or the capnograph monitors work on. So they infrared spectrography, molecular correlation spectrography, the Raman spectrography, mass spectrography, and photochastic spectrograph. Coming to the first one, that's the infrared spectrography. This is one of the most commonly used because it's very compact, less expensive, and easily available. Most of the popular manufacturers actually use infrared technology. So basic principle behind it is that all the gas molecules have a absorption spectrum for infrared rays. So the amount of light absorbed is directly proportional to the concentration of absorbing molecules. So a concentration of a gas can be determined. The carbon dioxide concentration measured by the monitor is usually expressed as millimeter in mercury. Coming to the molecular correlation spectrography, this is very similar to the previous one. The advantage of this that it uses the infrared emitter uses very specific range of infrared rays, and these rays are sensitive and specific for the carbon dioxide gas only. So obviously the monitor needs to take less amount of volume for the analysis. So it actually uses 50 ml per minute as compared to 150 ml per minute in the routine standard capnographs. The next one is a Raman spectrography. This is based on the principle of Raman scattering. Now we all know that the gas sample, when it is illuminated by a high intensity monochromatic argon laser beam, there's an unstable vibration or rotational energy state is created. This particular thing is known as the Raman scattering. And the spectrum of Raman scattering lines can be used to identify all types of molecule in the gas phase. So in the 90s and the early part of the 2000s, there were Rsacp monitors which were based on this principle. Coming to mass spectrography, this again uses the principle that when electric beam is introduced into a high vacuum chamber having the gas sample, it ionizes and fragments the component of the gases. And there's a magnetic field created, and the gas molecules actually move in magnetic field, wherein the radius of curvature is proportional to the charge and mass ratio. And a detector plate at the end of it, which depending on the charge mass ratio, it analyzes the concentration of each component. And the final physical principle is a photoacoustic spectrography, which is very similar to infrared principle, but only fact is that instead of measuring the infrared absorption, it uses an acoustic technique, which sees that whenever infrared is applied to a gas, the gas expands and lead to an increase in pressure. So if you apply energy in pulses, there'll be a pressure fluctuation. So this pressure fluctuation is converted to a acoustic signal and is detected by a microphone. So the advantage of the photoacoustic spectrography is that they have higher accuracy, better reliability, and less need for preventive maintenance. So apart from physical methods, there are some chemical methods also which are very important. So these are actually very useful when you cannot actually carry a capnogram with you. So these actually depend on a chemical substance that changes color with carbon dioxide and oxygen. So you see the carbon dioxide, it is yellow, and with oxygen, it is pink. So if you're doing a CPR out of hospital scenario, this is a very good method of confirming a endotracheal placement of your ET tube. So coming to the types of EtCO2 monitoring. So most of us know that there are two basic types, the mainstream and the side stream. So in mainstream, the technology in both of them are same, but in mainstream, the gas chamber is actually in line between the circuit and the ET tube. Whereas in side stream, 6 feet long tubing takes the gas from the sampling adapter to the analyzing chamber. So let's see what are the advantages and disadvantages of these mainstream and side stream monitoring systems. First, coming to the mainstream. So the advantage is that obviously there's no sampling tube, so there's no chance of obstruction. And also it is not affected by the pressure drop or water vapor pressures. There is of course no pollution and no deformity of capnogram because there is no dispersion of gases. There is also no delay in recording, and very suitable for neonates and children where the tidal volume is less. So when you actually take away 150 ml per minute, it is a little slower in neonates and children. So mainstream can be a preferred monitoring, EtCO2 monitoring. Yeah. However, the only problem is that because it is heavy, so in neonate and children, there can be a drag on the ET tube. So there can be disconnection or dislodgement. And it has a long electric cord. Sometimes facial burns has also been reported. Sensors may sometimes clog with secretions. And when you're using unusual patient positions like prone position, it is very difficult to use these ones. Sterilization can be a problem. Also, you cannot use it in patient who's spontaneously breathing. Now, EtCO2 monitoring is a long question for most of the postgraduates. So they need to learn all these advantages and disadvantages of both types of mainstream and the side stream monitoring. So coming to the side stream monitoring, so it's obviously easy to connect, no problems with sterilization, can be used in awake patients, easy to use in patients with unusual positions, and can also be used with collaboration with oxygen, when you're administering oxygen with nasal prongs or face mask. That's one of the biggest advantages of side stream monitors. And disadvantages are there's a delay in recording due to movement of gases from ET to unit. There can be sampling tube obstruction, which occurs many times, as you must all be knowing. Water vapor changes can affect CO2 concentration, and pressure drop along the sampling tube, which is 6 feet long, it's long. So that can affect the carbon dioxide measurements, and deformity of capnograms in children due to dispersion of gases in sampling tubes. So coming to the volume and type capnogram. So there were two types of capnograms available. One is a volume and a time. What we normally use is a time capnogram, but we need to know about the volume capnogram as well. So in volume capnogram, it is actually tells you only about the expiratory phase of the respiratory cycle. It doesn't give information about the inspiration. It has two parts. The part one tells you about the dead space ventilation. The phase 2 is a mix of both dead space and alveolar ventilation, and phase 3 is a pure alveolar ventilation. As there is no inspiratory part, that is one of the drawbacks, of course, of a volume capnogram. However, a volume capnogram can be used to calculate the alveolar dead space, the anatomical dead space, and basically dead space calculation can be done. Whereas a time capnogram, which is very commonly used, in the subsequent slide, I'll discuss about the various parts of it. So the basic physics of time capnograms, as we all know, there are 4 phases. Phase 0, which is the inspiratory downstroke. The phase 1, which is the dead space ventilation. Phase 2, which is a mixture of anatomic and alveolar dead space. Phase 3 is a expiratory plateau. There are 2 angles as well, the alpha and the beta. The alpha angle is approximately 100 to 110 degrees, but can increase when there's airway obstruction, there's a VQ mismatch. And the beta angle, which is normally around 90 degrees, so it goes perpendicularly down this phase. This can increase when there is a rebreathing. So in some patients, we may also see a phase 4, which is not seen in normal adults, but can be seen in obese patients or pregnant patients with reduced thoracic compliance. So what's a trend capnogram? So normally on an anesthesia machine, on a monitor, you see slow wave, with a speed of around 25 millimeter per second. That's a normal speed of a capnogram on a normal monitor. So you see only 3 or 4 complexes in the screen. But if you want to compare previous EtCO2 curves with the present ones, you need to have a trend capnogram. So you can, the decrease of speed to 7 millimeter per second will allow you to see more of capnogram curves on your screen. So you can compare the trend. So basically trend comparison is done with a trend capnogram. EtCO2 actually doesn't only give you idea about the respiratory status, the breathing status, the ventilation status. It also is a very good indicator of the cardiac output. So in a normal patient, say, for example, an adult patient of 70 kg, the cardiac output is 5 liters and the EtCO2 is 36. If all other conditions remain same and your EtCO2 is dropping down to 32, you assume that the cardiac output is also decreased. And it has shown to have a very good correlation, a linear correlation with decrease in cardiac output. So when your cardiac output goes down, the EtCO2 also goes down, provided the other conditions are remaining constant. Especially under general anesthesia, when your ventilation strategies are not changing, your volume status remains constant. So it can be a very good indicator of a cardiac output status. So what are the uses of capnogram? As we all know, it's a very commonly used, and in fact, the ACE standard for monitoring and diagnosing various conditions in the operation theater. But it has also found its uses outside the OR. So in the outside OR, in the emergency room, obviously ET tube positioning, to guide therapy depending on PaCO2, EtCO2 gap. So if it's a large PaET gap and patient arrested, young patient, history of DVT, yes, you can suspect a pulmonary embolism. Trauma patient, volume status, cardiac output status, success of CPR. We'll talk about this in the later slides. And rule out metabolic acidosis. This is in fact very interesting. While I was preparing for these slides, I came to know about this. In fact, most of us might not be knowing that metabolic acidosis has a very good correlation with the EtCO2. So they say that in a patient of diabetic acidosis, if the EtCO2 is less than 29, it is almost certain that the patient has a diabetic ketoacidosis. Whereas if it is more than 36, it's very unlikely that it is a metabolic acidosis. Similar conditions also apply to alcoholitic conditions like gastroenteritis, diarrhea in pediatric patients specifically. Capnogram is also very widely used during sedation and monitored anesthesia care, like in endoscopy units, cath labs, pediatric sedation for diagnostic procedures like MRI and CT scan, where access to the patient is very difficult, and EtCO2 is one of our saviors. Also in PSU and in ICU, especially when patients is given a high dose of narcotics for pain relief, breathing monitoring is very important, and for success of CPR and intubation. And also while doing percutaneous tracheostomy, the right placement of the tracheostomy tube inside the trachea is confirmed with EtCO2. So we'll next have a quick look at some capnograph examples, which is very important. So this is a normal adult, we know it's phase 0, 1, phase 0, 1, 2, and 3. During hyperventilation, as you see, when there is a hyperventilation, gradually the EtCO2 peak will come down. But remember that the base remains same. Similar with the hypoventilation, the peak will go up, the value will increase, but the base remains at same level. And this is apnea, it's self-explanatory. Coming to pregnancy. So pregnancy can come with many kinds of EtCO2, normal EtCO2 curves. So it may be absolutely normal. It may have a increased phase 3 slope, or it can, as we said earlier, can have a phase 4 also. Coming to pediatrics, pediatrics always have a faster respiratory rate, smaller tidal volumes, and relatively longer response time of capnograph, especially using a side stream capnograph. So they can have an elevated baseline, prolongation of phase 2, increase in slope of phase 3, or prolongation of the descending limb. Any of these is normal in a pediatric. Coming to lung condition, which we often face during our intraoperative conditions. So asthma and COPD and emphysema are common conditions, lung condition that we come across. So if we see at asthma, you see there is a prolongation of this phase 2, and this alpha angle is greatly increases, the increased slope of the phase 3, which is very typical of a asthma, and also it is going up. And coming to emphysema, so in emphysema, there is a lot of loss of alveoli. So obviously there is decreased alveolar ventilation. So the end part of this is a downward sloping emphysema curve in emphysema, which is very typical of emphysematous condition because of VQ mismatch and because actually of the alveolar loss. There is a downsloping phase 3. Kyphoscoliosis. Kyphoscoliosis often causes compromised function of one of the lungs because of the bony deformities. So you will see a differential ventilation. The two lungs do not equally add to the gaseous exchange. So you see one has a lesser contribution and another having a high contribution, leading to a differential ventilation pattern. The same thing is also seen if there is a single lung transplant, although these days single lung transplants are very, very rarely done. Coming to curaric rift, this is very important for all postgraduates who manage tables. So curaric rift is most commonly due to it's a sign of inappropriate or inadequate muscle relaxation, where you see this hump due to patient attempts. But however, you must always remember when there are too many surgeons, one having a retractor, one pushing, and there's a lot of abdominal manipulation going on, curaric rift like capnographs are not uncommon. And this is also very similar to Rsacp, but this is because of partial disconnection of mainstream monitors. This is very important. If you're using a mainstream monitoring and partially disconnect, you can easily see this kind of capnographs. So cardiogenic oscillation, these are normal, seen in many patients, basically thin built, and these are basically because of the pulsations of the heart. And there are many theories about cardiogenic oscillation. Some say that it is because of the contact of heart and the lungs, but some say it is because of the flow, the pulsatile flow through the pulmonary arteries that actually cause the cardiogenic oscillation. However, but these are very, very normal, so you need not worry if you have these. So anesthesia circuit related, this is very important. So if you look at a Mapleson D circuit, there is some scope of rebreathing here. So if you're using a Mapleson circuit, you can always see rebreathing pattern in the inspiratory phase. So that is because of the air here is rebreathed. Coming to exhaustion soda line, which is very common in the OT. So there's be a gradual elevation of the baseline and also increase in the peak values. We may also have some rebreathing pattern. Coming to machine valve defects. So here we are going to tell you, so this is a normal inspiratory valve, where what we see is during inspiration, the oxygenator is going, and during expirator, the red, that is a the carbon dioxide is going back. However, if there is a incompetent inspiratory valve, what will happen is the inspiration may be normal, but during expiration, because this inspiratory valve is open, the carbon dioxide will go towards the inspiratory limb, and in the next breath, the same will be breathed by the patient. So there will be rebreathing. So you will again see there will be a lot of rebreathing if the inspiratory valve is incompetent. Coming to the expiratory valve defect. So in these also, say if this is a normal expiratory valve, and if there is a abnormal expiratory valve, there will be a lot of mixing of oxygen and the carbon dioxide. So again, you will get a lot of rebreathing. Sampling line problems can also give you abnormal capnogram. There can be sampling leaks and breaks in lines, and this is a typical tail up sign because of the slit sampling line. Coming to metabolic problems, again, malignant hyperpyrexia and hypothermia will give increased EtCO2 and decreased EtCO2 values. However, these are not diagnosed solely on the basis of EtCO2 value. There are a lot of other clinical signs which need to be looked at when we are when we are anticipating these conditions. Coming to esophageal intubation, so we can have absolutely flat line, some undulating lines. However, these are the conditions when we are actually worried. It looks like as if we are getting the EtCO2 curve, but this could be because of the air entered the stomach during mask ventilation, and normally in 5 to 6 breaths, they die down and you will start getting one of these flat lines. And sometimes if the patient has consumed a carbonated beverage just before being intubated, that also can give you some bizarre EtCO2 traces. Endobronchial intubation again can give you a differential ventilation pattern in the capnograph. And this is very important when you have a cardiac arrest and you're doing a CPR. EtCO2 has been recommended by the ACC-AHA as one of the monitoring tools for guiding the CPR, and it is said that at least 10 millimeter of mercury trace value should be there on the capnograph for success of CPR, and if it is more than 20, the chances of a good outcome, a favorable outcome, is very high. And last but not the least, pulmonary embolism, whether air or thrombus or fat embolism, they all cause a sudden decrease in the EtCO2 value. So anytime there's a sudden decrease in EtCO2 with suggesting conditions intraoperatively, pulmonary embolism should be suspected. Now, next, I'll go on to some scenarios, and this is specifically for the postgraduate students. And these scenarios are not just based on the capnogram, but capnogram, of course, is an important part of the scenario. And I would like them to come up with suggestions and participate actively. So are you all ready? I want some kind of participation from you so that it's really interesting then. I want you to unmute when you want to answer. So
Yeah,
let's
we
go to
have the chat box too also. They can put in or they can unmute themselves also.
Sure, ma'am. So on a first scenario is that on a busy day in the operation theater, the fourth case for the day was induced at 2 p.m. So assuming that the OT started at 8:30 or 9, so at 2 p.m. there was an induction of a case, which was 54-year-old AC2 female and weighing around 52 kgs and undergoing mastectomy under general anesthesia. After an uneventful induction and intubation, patient was put on ventilator with the following settings. Tidal volume of 400 ml, respiratory rate of 14 per minute, PEEP of 4, fresh gas flow of 1 liter, FiO2 of 0.5. The monitor readings at that point of time were heart rate of 78, BPO 120/76, SpO2 98%, ECG was sinus rhythm, and P airway pressure was 18 centimeter water. So suddenly the in-charge anesthesiologist saw that there is this pattern in the ETCO2, the capnogram. Now, I hope all of you have understood the question well. So it's a 54-year-old female being 52 kgs for a mastectomy, uneventful induction intubation. The ventilator settings are there. And the monitor readings look absolutely fine. Only that there is some problem with the capnogram. Now, I want the postgraduates to identify the possible condition and answer to this question. So which of the following is not the right thing to do? Increase the fresh gas flow to 6 liters per minute, increase the tidal volume to 500 ml per minute, or change soda lime. Now see, it's a 52 kgs. So I guess this is sufficient. The tidal volume is good enough. And respiratory rate also looks good. And the major clue in this is that it's a fourth case for the day. Perhaps the soda lime has not been changed. So it's possibly a rebreathing that is happening. And as we see, there is an increase in the baseline. So it's possibly increase in CO2 peak along with the baseline. So it's rebreathing, possibly due to a soda lime exhaustion. And we can either increase fresh gas flow if we do not have the possibility of changing the soda lime while we are going on with the surgery, or if it's possible, some machines do allow change of soda lime while it is still in use. However, increase of VT will not change your condition because rebreathing will continue. So
there were few answers in the chat box.
Oh, I guess I didn't see it. Oh yeah,
one of them was soda lime.
Yes, right. So I think I didn't see that. I'll go to the next question. So it's really nice to see the students participating. So the next is, so this is a scenario 2. This was a 45-year-old chronic renal failure patient on regular hemodialysis. And he was undergoing abdominal surgery. That's a D2 gastrectomy under general anesthesia with endotracheal tube and IPPV. Standard AAC monitoring was used along with neuromuscular monitoring to guide etrocurium dosing. So for neuromuscular monitoring was used for muscle relaxant use. Now, intraoperatively, a final year trainee resident was managing the case. He suddenly noticed the following changes in the capnogram. And what were the changes? I'm unable to, okay. So suddenly what he saw was that there was this pattern in the capnogram, which is a change from the normal capnogram earlier. And this continued for some time. However, at that point of time, the other values in the monitor were blood pressure of 130 to 74, heart rate of 76, SpO2 normal, ECG normal, temperature normal, and a trainer 4 ratio because we're monitoring a neuromuscular, you're using a neuromuscular monitor. The T4 T1 ratio was 0. Again, my question is, what is the next best thing to do? give a dolus dose of etricurium, ask the surgeons to move away from surgical field and recheck capnogram, ignore and proceed with the surgery. Okay, so this is spontaneous breathing, good. Okay, due to abnormal manipulation. Okay, so many of them have answered correctly. So now, if you look at the case, yes, it does look like a curare clef, but you must remember that you are doing a neuromuscular monitoring and the T4-T1 ratio is 0. So obviously, it is not a case where you want to give a neuromuscular monitoring. And you should remember there's a chronic renal failure patient also. And at the same time, there are a lot of surgery, D2 gastrectomy, very close to the diaphragm, a lot of surgeon involved, abdominal manipulation. So always recheck before giving a dose of etricurium. Please do not ignore and proceed with the surgery. Do something about it. So shall we go to the next scenario? Okay, so this is the final scenario. So that is a 28-year-old male weighing 70 kgs, height of 180 centimeters, but undergoing a posterior facet surgery under GA in sitting position. Now that is a lot of clues, of course. So the patient was being monitored with standard ASA, basic monitoring, along with an arterial blood pressure, central venous pressure, temperature, urine output, and a transesophageal echo monitoring. The baseline ABG for this patient stands like this, with a ventilatory setting of FiO2 0.4, tidal volume of 475, rate of 14, and peak of 4. And the vitals were absolutely within normal limits. 15 minutes into the tumor excision, there was a significant bleed causing more than 20% fall in the mean arterial pressure. And fluid and blood were transfused and mean arterial pressure returned to normal. Now, 10 minutes later, there was another episode of severe bleeding from the torn venous sinuses. And at that point of time, the heart rate increased to 140. SpO2 went down to 92. Blood pressure was low at 84/42 and falling, not responding to volume. EtCO2 was 20 and falling constantly. ABG at 7.28, PO2 58, and PCO2 of 54. And the EtCO2 values, initially 37, now are at 17. The next best thing to do: continue with the surgery, do TE to look for hypovolemia, possible MI, and call for help. Continue blood and fluid transfusion, continue surgery, 0 monitors, call for help. And third, stop surgery, pack the field, do TE to look for air, and call for help. Now, I want you to diagnose. I guess that is very evident now, and I want you to tell me the answer also. Yeah, great. Most of them actually have answered it correctly. But then there is a TE, so it's the diagnosis is very easy here. But apart from that, although EtCO2 is a good indicator of pulmonary artery embolism, venous air embolism, it is not an absolute indicator and may take time. And all these vital parameters like heart rate can go down even when there is a lot of volume loss, and SpO2 can go down because of hypotension as well, because of other causes. So EtCO2 is one of the adjuncts in this case, but normally not the only sole monitoring tool. So with that, I end my talk, and thank you. I'd be happy to take any questions.
Yeah, somebody can, Dr. Basant Pradhan or Madam Indrani ma'am can speak a few words. I think that was an excellent talk by her. Yes. I would request our chairperson or a president to kindly speak a few words.
That was such a brilliant lecture, Prachi. I think you explained capnography so incredibly well and in so much detail. And I'm sure all our students love this lecture, and they have lots to learn from the lecture. And thank you very much for an incredibly wonderful presentation.
Now over to our chairpersons. Would you like to sum up the session, and then we can ask our seniors to speak a few words on it. So please. Vasant Pradhan sir and Dr. Bimal.
Definitely, it is a brilliant talk. So it's with the question scenario, it is very much helpful for the postgraduates as well. What they have learned during the session, they have answered very well, and most of them they have participated very well also. So over to our second chairperson, Professor Bimal Panda. Let him talk something about this topic as well as this presentation also. Bimal Panda. Bimal, are you there?
Yes, he's there. Dr. Bimal.
Sir, you have to unmute yourself. So please unmute yourself. Unmute yourself, sir.
Please unmute.
Okay.
Dr. Bimal, please kindly unmute yourself. Yes.
Okay. Am I? Yes. Actually, the host didn't allow me. Thank you very much, Prachi. It was indeed a very nice presentation. As always, I know Prachi from MBBS career, and he was very meticulous, and he never left any stone unturned. And the preparation shows the same thing. Many things, what many things? Everything he covered. Only one thing I can add, that everybody should be cautious while putting an endotracheal tube, because if it enters beyond the vocal cord or it is above the vocal cord, the tracing will be same. So once the surgery is on, you must be vigilant, because if it is above the vocal cord and dislodges, then capnography will be the earliest to detect. Thank you, everybody, and thank you, Rsacp, for giving me this opportunity to chair this session. And thank you, madam. Thank you all. And if anybody has any query or question, it is open.
So before we end, one more thing we can add, that in volume capnography, we can also adjust the PEEP in mechanical ventilator positions to get the best FiO2 as well as to get the best ventilation, alveolar ventilation.
Well, actually, sir, I didn't add too much about volume capnography, because we normally do not use it. And I didn't want to confuse the postgraduates with too much of information. The time capnography is what we normally use. So actually, I have a few hidden slides in my presentation, which initially added.
Short time, you have touched everything. Definitely, it's very trustworthy and definitely an excellent presentation. Anything from the audience?
Yes, I would request our senior sirs, Dr. Tejpal sir, Dr. Naveen sir, to kindly put in their inputs, to give their inputs in this. Naveen sir, would you like to give your inputs?
Protocol, sir wants to say something, please, sir.
Okay, sir, kindly.
Dr. Prachi's presentation has been excellent. It is not only excellent, she has discussed the subject in very easy, understandable way. Very simple and understandable way, which anybody can understand it.
Thank you, sir.
I wish the organizers make such lectures more frequent. Not only everyone has been stressing that it is for the learners, the PGs. It is not only for PGs and the learners. It is for everybody. Even me at my age do realize many things and understand many things. The more and more you know about it, the more and more things become clear. So I would suggest that such lectures must be, such webinars must be encouraged for the betterment of definitely the beginners and the learners and the PGs, but for everybody, and everyone must attend it. Thank you, Rsacp. Thank you, Dr. Rekha, Dr. Nibrita. Thank you, the organizing governing council, the president, Dr. Indrani, Dr. Naveen, everyone associated with Rsacp, particularly Dr. Vishal. Without him, nothing can move. Without Vishal, nothing, no stone can be turned. So thank you, Dr. Vishal. Thanks, everyone. Long live Rsacp. Excellent.
Dr. Naveen, sir, would you like to say something?
Thank you very much. Both the speakers were excellent, simply excellent, and I enjoyed each second of attending both the lectures. Heartiest congratulations to you, madam, for calling such exceptional speakers, and both Dr. Prachi and the cardiologist, you were excellent. Thank you very much, and it's 8 o'clock, so better time to wind it up.
I'll just say a few words.
Yes, sir.
Both lectures had unwavering attention from all those who attended. And I would like to thank Dr. Tejpal and Dr. Naveen Malhotra as usual for his support, for their support and guidance. And well done, Team Orissa. Thank you very, very much. And I wish to thank all of you for attending this excellent session. As Dr. Tejpal said, not just the residents, even all of us have learned a lot from this. And till we meet again, adieu and good night. Thank you very much for your patient hearing.
Thank you, ma'am. Thank you, my seniors.
Long
and
live
speakers.
Rsacp. Long live.
Long live Rsacp. Thank you, ma'am.
Thank you, everyone. Long live Rsacp.
I'm also thankful to our young people here, Dr. Tanvi, Dr. Rakesh, and Dr. Navdeep, because they are also very, very intelligent. They're very learned people in this field. So unfortunately, we did not have much time to get some inputs from them, but I'm sure they must have also enjoyed and we could have heard them, but maybe sometimes later on. Thank you again. Thanks.
Thank you.
And regards to all the seniors.
Madam Rekha, you are the host, so you have to close the meeting.
Okay, sir. Okay, sir. So I'll finish it. So everybody I'll do it at the end. Okay, sir. Good night to all.